A very good afternoon to all. So we welcome you all to the instruction course on communication, psychology, litigation, and tough patient. So what are you going to expect from this course is like a lot of times we come across an aggressive patient and we don't know how to deal with it. So we are just going to talk briefly on how to communicate with those kind of patients, importance of a consent, how a consent should be taken, what points should be highlighted in anterior segment, posterior segment, ROP, cornea, refractive surgery. Then it looks a bit different and off topic, but nowadays, as we are doing more and more good number of cases and premium cases, a lot of patients have expectations and they want 6/6 vision, clear vision with no complications. And they try to blame your surgery. So a role of psychiatric couch there, and a lot of times we get referrals from our colleagues thinking that we have a complication. So how do we deal with your colleague's complication? So, and it's going to be an open house case-based discussion. So we just, anyone has questions anytime, you can stop us. Any suggestions also, you can stop us and we can discuss here. I'm going to be joined by Dr. Anand Vinekar sir. He's a pediatric ROP specialist and he runs the kid ROP program, which all of us know about. So he's going to be helping me to conduct this course. Anand sir, can you just take over?
Thank you, Pooja. So as she outlined, this is going to be a slightly different course, not just in the content, but also in the way we want to conduct this. It's going to be, obviously, we are not legal experts. We've taken some help from legal experts, but mostly drawing from our own experiences of our colleagues. So we'll also switch orders slightly because some of our speakers are caught up in other sessions. So this may not be the order in which you might see it in the program.
So we'll start with consents in anterior segment, posterior segment, and the points to be highlighted and which shouldn't be missed in your consent forms in your practice.
So while they set it up, I thought I'll just detail something about consents. It's very interesting on what we fear to take in a consent, and what we actually end up taking is not sometimes what is required in law. I was speaking to some lawyer friends, so some of you all who know me, I work in the field of pediatric retina, so a lot of, 99% of our patients are minors, so consents become even more difficult when you're looking at an adult giving permission for a child, that too for a treatment that may even be off-label. So it adds a few more layers of complexity. So went down to, okay. As we know, in Bangalore we have the National Law University, and so we have some friends there. So we discussed, so they have a very nice collaboration between the National Law School and the Indian Medical Association. So they're working together on how to reduce litigation, especially against doctors. So there are a few points that I understood from interaction with them. Firstly, even though we think video consents may be like a really cool thing to do and maybe protect us against many problems, still under law, the written word is sacrosanct. So that's the first important take home that I got. And except in emergencies where, and we don't deal with them too many because we are in the field of ophthalmology, but if you are in accident and emergency kind of setup, you can actually even operate and maybe even end up not being successful, making the patient survive and still not be medico-legally liable. So other than emergencies, consent is absolutely essential. The own language part is something that we don't really look at. We think our very fancily worded English language consents, which deal so much with the language and the science, is enough. But quite clearly, the law will not look at it favorably if we've not explained it, at least in proof of it, that we've done it in the local language. What is the absolute foolproof method of getting around this problem is to firstly get them to understand it in the local language, sign it or sign a consent that is in the local language, preferably also translated in English to prove that you've done the right science behind it, and then have that signature and the fact that that person or patient has agreed to the consent taped on video. That is supposed to be the foolproof. Now, Do we do that in all cases? We certainly don't. But certain clinical trials, for example, demand that we have video consent. So this is something to keep in mind. So this is like the final field. Like if you can actually end up doing a written followed by a video one, then that's the only one that is foolproof. And that is the journal in which they published this professional code of etiquette and ethics in 2002 and apparently not been revised since. So in law, there are just two types of consents, implied and expressed. So if a patient walks into your office as an ophthalmologist, the fact that you are examining his or her eye is implied. But it is not implied that you're going to suddenly start auscultating that patient. In other words, if a patient enters a gynecologist's office, certain examinations are considered implied because that's part of a gynecological procedure. So the moment you overstep what is considered normal examination methodology for you, then you have to take consent. And this does not have to be written. For example, Mr. So-and-so, can I look into your eyes is enough. And if, of course, that patient says no, then why did he walk into your office? That's the next question. But you have to take that one oral consent even when it is implied. And I think all of us do that. Many of us who've done foreign exams know that you will fail if you don't introduce yourself and say that I want to examine your eye or whatever. So, and it also falls on the fact that if the patient comes in, the patient is supposed to follow the diagnosis as well. And expressed can be two types, oral or written. Written, of course, we'll come to. So there are only two prerequisites according to law. Firstly, the person giving the consent has to be mentally sound. Now, obviously, this does not apply to pediatric patients because they may be mentally sound, but they may be even pre-verbal patients. So we'll deal with that. And then informed, so all information that will prevent a case of negligence. It is so gray zone worded that really how much information is enough information. That's where the lawyers really score over you because you're an expert, but you won't be able to defend that in court. Now here is a wonderful article, real consent and not informed consent is applicable in India. Now this is something that I wasn't aware of and I discussed it with my lawyer friends. So what is a real consent? There are only three aspects. Firstly, there should be enough knowledge, and we can debate on what enough is. Second, they should have the capacity to understand, which means they should be mentally not challenged and they should not be inebriated or something like that. And third, they should have done it voluntarily. So these are the only things. So they call it the DCV thing, the disclosure, capacity, and voluntariness. And this is based on the United Kingdom or the UK court system, and our Supreme Court uses this. Whereas the informed consent, which we all believe is the one that we have to take, has so many more layers. So there we talk about the nature of the disease. We want to tell you what problem you have, what our treatment will do, what are the other forms of treatment, what happens if my treatment doesn't work, how am I going to take care of the complications if it goes wrong, and many other things we keep on adding into our consent thinking that it is foolproof. And this has been made in the United States to prevent litigation. So the UK one protects patients, the US one protects doctors, and this is exactly how the law looks at it. Now here is the most important fact that came out of our discussion with the lawyers, that the Supreme Court of India in 2008, and I believe this hasn't been revised in the past 12 years, only wants us to take a real consent. Which means you don't have to add all of those layers that we've been adding. We are doing it for our own protection, fair enough, but you're not going to be held against that if you've not done it, because I'm just going to read out from that. But if the medical, so we have, however, consciously, and they're referring to that case, but if medical practitioners and private hospitals become more and more commercialized, and if there is a corresponding increase in the awareness of the patient right among the public, inevitably a day may come that we may have to move towards the Canterbury system. The Canterbury system is the informed American system. And the last line, but not for the present. So of course the Supreme Court falls back on its own precedents. So if you're caught in a case between now and the next revision, you can always say that, Honorable Court, you had said that the real consent was enough. I'm not saying that you don't need to take informed consent, but just be aware of your legal rights before you get pushed into something. So this is a LASIK consent, and my colleague Sharon was supposed to talk a bit about it. Pooja, you want to?
So what, like we all know what we take in the LASIK consent, like everything has to be explained about regression, ectasia, infection chances, or inflammation, or when in future you may get cataract, presbyopia. So all those points are important. But off lately, what we have been seeing is a lot of patients come back with glare, halos, and regression. So are these patients actually having glare and halos? The answer is no. We are in a millennial generation, which I'll be also touching upon when I talk about the psychiatry couch. So we are in a millennial generation when all the youngsters, including they're always on mobile phones, they're always on computers. A lot of IT people, they get operated for refractive surgery. So what is important and what we have added is, because when they come back with glare and halos, few of the patients, we did an orthoptic evaluation. And what we saw was that a lot of these patients had vergence and fusional problems. So that's when, then they need orthoptic evaluation and orthoptic exercises. But at that point of time, how are you going to explain the patient that this is not the regression? This is not the power has come back. You have to tell them that this is the muscle imbalance, and that is maybe because of your profession. So what we decided that, when the patients later on come, back with all these problems, we'll rather add it in our consent. So this is a very small consent where we have added that, some patients may have a pre-existing eye imbalance and muscle imbalance and orthoptic related issues, which is missed because a lot of them are myopic and they might not have a problem before surgery, and we cannot pick up. So after surgery, if any of these complaints you come back with, you might need an orthoptic evaluation and exercises for the same. So now they are not going to understand what orthoptic is. So you, in a very simple language, you can explain them that it is, it's a physiotherapy for your eye. So this is what we have added in a consent, and when we are counseling the patients also, we make this thing point very clear. So the incidence of unhappy patients have reduced by around 70%. So this is the importance of one latest thing which we have added in the LASIK consent.
Thank you, Pooja. I also want to add that the LASIK department gives out this consent a day or sometimes many days before the actual procedure, and takes a signature noting that the patient has received this consent. So there's proof that you've given it to them, and the patient is told, read it and come back if you've made up your mind to undergo surgery. And I think this is important for surgeries like these, where it's not other kind of surgeries where the patient demand is also very high. And when they come back, it is now implied that they have read it, understood it, and cleared all their doubts, and then they sign it and give it in. So I think that's really important. And I know that Sharon put this in here because she said that in very high-risk cases, I'm not sure which one this is here, but in very high-risk cases where failure, especially for grafts and so on, is more likely, handwritten consent is also what they add into the file. So in addition to all of this, it does not have to be the handwritten of the patient, I believe. Even the doctor can handwrite it, but it's read out to them, and then when they agree, they sign. So this is something, an add-on, because this could help you in the court. I'm just coming to a little more familiar retina ground, so I'll take it from here. Well, I'm just going to discuss consents more generically, and I'm not really trying to give you consents here for any of the procedures I'm showing you. But let's see if there's a standard format. So fortunately, I don't know how many of you all are aware that AIOS has a book of consents that they've sent out to members. Has anyone not seen it? Okay, good. So yeah, so I guess that takes care of many of our problems, because you can fall back on the society saying this is what the society prescribed. So like this one, for example, the intravitreal injections that we use in our institute, we've just downloaded the VRSI form, and then we've added a few things. So the addition is something that you will have to customize for your own institute. So of course, in an NABH institute, you want to add what they call a controlled number. And here, so this is an example of an informed consent. So here you're adding in the indications, and then you're talking about regulations and how that it may have not been off-label and so on, the limitations of, so this is almost like a short answer in a question, like in an exam. You don't really need to inform this to the patient, but this is where I think VRSI is taking a very strong stance, saying, these are the facts that we know, this is the lacuna in the information, but this is still good for you, and this is what we are going to do for you. And that's exactly what we are doing. And of course, bleeding in the eye, these are, as you can make out, written in language that can be understood. We are not talking about retinal hemorrhages or choroidal hemorrhages here. We're talking about bleeding in the eye, and that could be anywhere from conjunctiva to retina. And this is exactly the language in which it has to be communicated to the parent. So look at, to the patient. Glaucoma, increased pressure in eye, and so on. So we're lucky that VRSI has this consent. Now let's go on to what I was talking about in a minor patient. So the best example for me would be ROP. So obviously, few things change? Firstly, obviously you'll need a parent signature. We believe in taking both parent signature, and sometimes there's only one parent, so that doesn't matter. You can have another relative and mention the mobile number and the relative patient of that. So what are the additional points that we've added? So this is consent to actually examine a child, just a regular ROP screening. It could be indirect ophthalmoscopy, it could be imaging, this doesn't matter. This we have created on our own because there was no precedence. The laser ones, a lot of formats do exist. So what have we added? So let's go over the steps. The diagnosis, that is ROP. What are the chances of success? Obviously depends on the type. The failure, obviously, what are the possible complications? Why do you need to long-term follow-up? What kind of anesthesia and approximate duration of the procedure? And what is the need for follow-up? All this should be told to them, and that's why it's included here. Now one more layer of difficulty. So you have a minor patient in which the treatment is a off-label use. So here now you're giving an intravitreal injection. Of course we give it, but there's no provision under law that can be protected if something goes wrong. And this is like once in every week there is a query in the Indian ROP Society, give us a consent, give us a consent. So this is now using that line of what the Supreme Court said, we are going 5 steps ahead in this. We are going informed plus plus. So here we are talking about, we directly tell them that it's an off-label use, we talk about the disease, and then we add some what is called in law a theoretical construct. So we say this is not the sole therapy, you might need to undergo another injection, maybe another laser, even if it's successful, what it means. Success to you and success to a mother may be different. For a success for a mother means good vision, but an APROP baby may have bad vision because of some brain issues. So all of that has to be kind of constructed here. And the approach is fairly defensive. If you read some of the lines here, it says, off-label, I told you so approach. The I told you so approach is to say that, I told you that things can go wrong, rather than take a positive approach saying, things are usually going to go right. Because that is the back foot you have to take when you're taking an off-label. And this would apply if you were doing procedures that were experimental, which are not under the gamut of a clinical trial. So you will have to go this extra mile for these kind of consent. And then of course talk about the dosages. In this case, we don't even know what is the right dosage. So you have to mention that. And whether you're going to do both eyes on one day or on subsequent days, this is a big issue because, what is the legality if both eyes have endophthalmitis in a off-label use? So this is something that you need to explain to them, that are you willing to get it done on the same day or consecutive days, and the unknown systemics. But finally, you must end like this. So everything possible will be done to ensure that the disease is treated in the best interest of the child. There has to be language like this which says that you are doing it in good faith. And this is not written here to make it sound like a nice consent. This is a legal requirement. Because when you're doing off-label, you have to prove that you're doing it in the person's good faith. With the limitation of knowledge, that's how science is advanced. So that's all I actually have to say about consents. We'll probably go on to the next talk. If anyone has questions at this point of time, I'd be very happy to take it. I think AIOS would have probably sent it to your home address, but you can check with the AIOS office. It's one of the AIOS publications that they have. It should also be available on the website. Thank you. It's available outside the trade. Yeah, thank you. So while we get it set up, I wonder if you all were aware that to reduce aggression and sort of physical insults against doctors, the Indian Medical Association is now working with an organization called the Association of Healthcare Providers of India. And they are engaging governments at both the central and state level. And there is a very large team of people who are looking at possible strengthening legislation and also enforcing it to improve the sort of the way patients look at doctors. And that's something that's going to go a long way. So, well, we have Dr. Pooja now, who's going to talk about the virtual psychiatric couch to understand personalities, and this will go a long way in understanding the kind of patients we treat.
Thank you, Anand sir. So, be it anterior segment or posterior segment surgeries, mainly the anterior segment where we have to give our patients like in cataract and refractive 6/6 vision, if they've undergone a premium surgery 6/6 and 6 vision. How many of you come across patients who come back to you after 3 or 6 months and say that we are unhappy, you've made our life hell, and whatever you want, you get me back to normal? How many of you get this kind of patients? And how do you deal with them? If everything is, if all your ocular and examination is within normal limits. Yes. So what do you do with them? Yes. So exactly. So a lot of times when, after surgery also your surgery has gone well, doctor is happy, the ocular examination and all is happy, still the patients are complaining. You've ruled out everything, the lenticular, the retinal, the corneal, all changes. Still they have a complaint. We need to, it sounds very funny, but those are the patients who have some other problems. So what we call is, it's a psychiatric couch. I have no financial disclosure in the talk. I'm going to be talking about refractive surgery, but it can apply to glaucoma, cataract and all. So as I said, uneventful cataract surgery, post-op 20/20 vision, few patients come back with unhappy outcomes. So what is this elusive link? Is there something which we are missing? Yes. What are we missing is the personality of this patients. Even though we deny or not, we all of us have many moods. So when the patient has walked in your clinic, you don't know what is the mood of the patient. Sometimes the patient is going to be happy with you, and you don't know what's the actual personality of the patient. But after the surgery, the patient just wants something to blame it on you. So that's why the personality is very important, especially in anterior segment surgery. How do you define a personality? There are two components of it. One is nature, which is the genetic and the hereditary part, which we are in the family, but there is nurture as well, the environmental variables and the upbringing. A lot of us youngsters now go out and stay in hostels. We have different friends, we grow in a different culture. So even though the genetics and the hereditary is normal, and a lot of us have different abuses, so all that affects the personality of the patient. So that is why it affects the outcomes of your surgery. So I'm going to be very basic. So what we did was, we saw the literature that is there any work done on it, and we saw that in keratoconus, myopia, glaucoma, they have done a personality evaluation of these patients. And they've used a questionnaire, and they've seen that a lot of these keratoconic patients who have been having abnormal vision since childhood, myopic patients, glaucoma patients who are on a lot of medications, they have a personality issue. So we went and checked the same questionnaire, which is called the ICING personality questionnaire, which is a validated questionnaire. It is freely available on Google. It's a 54 question answer, just yes or no. Don't tell your patients it's a personality questionnaire, just give it to them with a blank one. And what happens, you don't have to do anything. It gives you a scoring, and it actually also tells you whether the patient is lying or not. So this is how the questionnaire looks like. It tells you whether its patient is extrovert or introvert, whether the patient has a neurotic problem or not, and whether the patient is lying or not. If the score is more than 5, it means that patient is lying to you, and that is a red flag sign that you wouldn't like to operate this patient, because if you are going to operate this patient, you are going to burn your hands. So it gives introvert and extrovert, stable and neurotic personality. Based on a combination of it, it is either divided in phlegmatic, sanguine, melancholic, and choleric. So what do we do? How do we identify this trait? If it's a phlegmatic, it means a good personality, calm, cooperative, agreeable. These are the good patients. Even sanguine is a good personality because cheerful, energetic, and optimistic. But when it comes to melancholic or choleric personality, these patients are always dissatisfied and anxious with whatever you do. They are impulsive, they are aggressive, and they are restless. So these are the two groups you have to be very, very watchful about. You don't do it for all your patients, but I'll tell you in the next talk that when do you use this questionnaire, and these are the red flag personalities. So what we did was, we just did a questionnaire. We did a refractive surgery, and post-operative at 1 month, we did the quality of life assessment to see whether there's actually a correlation or not. What we found was that a lot of the patients who had driving issues, depth of focus issues, or had problems in outdoor activities, it was based on all this questionnaire, a simple questionnaire. So your patients are also not going to question you that why are you taking this thing from me. What we noticed was that the melancholic and the choleric, which are the red flag personalities, which are the bad personalities, had lower quality of life post-operatively compared to that of phlegmatic and sanguine personalities. Means that if you're doing a questionnaire for these patients, you probably wouldn't like to operate these patients, and even if you operate, you would like to take a special consent or an in-depth counseling for these patients and then operate these patients. So what do we do in our clinic? Whenever the patient walks in our clinic, a hospital staff, your hospital staff who's sitting at the reception or who's counseling or who's registering the patient are very important, because they can notice the odd behavior or any impatient behavior from the patients. A patient who's asking a lot of questions, anxiety is different, but a patient who asks a lot of questions also is a red flag sign. So hospital staff can actually identify this. If it is something, you can give the EPI questionnaire to these patients. From this EPI questionnaire, you can actually figure out if the patient is a liar or a melancholic or a choleric. If then the patient goes to the doctor, never tell your patient it's a psychiatric problem. Always blame it on hormones or any other body problem. So treat it with a psychologist. Also, don't tell that the patient has to, we are referring you to a psychologist. Tell the patient that, it's just a friend of mine. If you go and talk to the patient, doctor, if you share your problems, you'll probably feel better. So never, never, never use the word psychiatric illness. And or if it's a, as I said, if it's a choleric personality, do a psychological illness evaluation and treat it with a psychologist. If it's a melancholic personality, you can, because this is a slightly better personality, so you can operate this patient, but be very precautious, in-depth counseling and a special consent. And if the questionnaire gives you everything within normal limits, you can go ahead with the refractive surgery. So melancholic, lonely and moody, increased chair time, you need to understand their flow of thoughts, because whenever you're talking to them, it means, they suddenly, while they're talking, within brisk of a second, they change their, what they're talking. So it also gives you a clue that, this is not a stable personality. Involve family. Also involve that how they're behaving with their family members when they're sitting with you. If the behavior with the family members is not appropriate, that is also a red flag sign to you that, this might not go well after surgery. So rule out and very importantly, rule out the history of substance abuse, because a lot of times when the patients are young, it only means smoking and drinking, and which is normal in today's era. But smoking, it is not it. You also need to ask what kind of smoking, what substance they are taking, because a lot of times when these patients are on opioids or any other form of drug, also it can affect their neurological things, the pupil reaction, and they can have a post-op unhappy vision. So also rule out the history of substance abuse by digging in. And you can do an orthoptic evaluation, just the muscle, as I said, the muscle evaluation, if they're okay or not. And if any of things, postpone the surgery, wait for 3 months. You can probably after 3 months, once the patient has visited the psychologist, repeat the questionnaire, and if everything is okay, you can go ahead with the surgery, but that too with an extra precaution. So what we have done is we have made an app here, which is like you don't need to go on a Google. It's just a link where you can give it to the patient in the mobile, which is not written. It's a psychiatric questionnaire. The patient answers yes or no, and at the end of it, you don't need, again, it just gives you the answer what kind of a personality is. And this is one another personality, as I said, choleric are the patients who are always restless, who lie a lot. You can probably refer to a psychiatric clinic saying, probably there's a hormonal imbalance, why don't you just go and talk to the patient? Blame, as I said, blame it on a physical or a hormonal issue. Never use the word mental illness, and always discuss and refer the case. Just don't send the patient and forget about the patient. Always go back and discuss with a psychiatrist or psychologist where you have referred the patient that what the problem is. So you can co-manage the case, and those patients are always going to be better rather than just losing their thing. Thank you. Do we have any questions? I would be happy. I can share the link with you, but it's the icing personality questionnaire.
Where is it is available? Questionnaire is.
Dr. Gairik is here. He can share the link with you, sir. We'll just we can WhatsApp it to you once it's ready. Yeah. It's like a Google form, so that because when you do it on a Google, every time you have to make the patient wait and then calculate it and all. So that's why we have made it in a Google form, where after you're done with the question, it goes in an Excel sheet and gives you the result. So it's not actually app, it's an Google form. So he can share it with you.
Is there any standard question or some 10 to 15, how much questions?
54, but just simple yes or no. How is your mood? Do you actually react to situations like bad situations in the family? Do you like to spend time with your friends? So they're very simple questions. So the patient is not going to know it's a psychiatric evaluation. Do you like to go out? How frequently? When you go out, what you like to do? All those type of questions.
Thank you.
So it's a routine evaluation. This helps us in evaluating your outcomes, because when you undergo a surgery, after 1 month we will be giving you one more questionnaire, and it will help us to modify your treatment accordingly.
And she mentioned something about how to detect, besides the characters, whether a patient is lying or not. So all of us tried out the questionnaire before we paid. So how it picks up the lie bit is that it gives you certain questions where you are tempted to give an answer to sound good. Means you want to be, you're scared that if somebody reads this and I actually answer like this, it won't look good on me. So, and then the questionnaire is fairly smart that it asks it in different ways across the questions. I think there are 50 something questions. So, you know that you have written that, you have ticked that option to sound good, or because you really are good or feeling good. So that way, so it's like, it's like many questions in many tests, 10% of the questions are repeated to look at intrapersonal, intra-observer variability. It's like that. Only it twists the question to get the same fact out, but one of them makes it very obvious for you to pick the bait, and the other one actually tests you. So it's simple, but yes, it is in the English language. So these are some of the disadvantages. So I guess you will have to have a sort of a decently literate patient who understands the language, and some of the questions can be, you have to think about it. So if you have a patient who is so probably depressed or so melancholic, who doesn't have the patience to write it, to answer that, can just be ticking away happily to just get rid of the question. So these are some of the limitations, but and that's probably why the example she gave you was for cataract or for refractive surgery, where anyway the more educated patient and the more demanding patient comes in. But trying it out on a patient who would not understand the English language well enough, as of now, it's not been translated, right?
Yeah, it's a very interesting point. Like, we did not get a clue from only the medical published literature. A lot of MBA people, when they go for interviews, like big companies like IBM, Novartis and all, they actually give their, the people have come for interview this questionnaire. Because for them, it's very important to know whether this person is going to be a team player or not. So they have a different set of questionnaire, and that's where we got a leak from, that, this might be like useful for our patients as well. So it's just not in the medical field which is being used. Like when you go for a recruitment also, this might be used. So I think in between we'll
have the keynote. Yeah. So while we're waiting for our other speakers on the other session, may we invite...
we extremely apologize for the inconvenience.
May we invite Ms. Renu Wadhwa, who is delivering the keynote, and she's going to talk about managing finances in a community ophthalmology institute. And I think that's so important because firstly, ophthalmology itself is a field in which our returns on investment is something that we measure not just in terms of the finances, but also in terms of the outcome we give the society. And then when you do that in a community setup and then manage that well, I'm sure that's a big challenge, and we're happy that Ms. Wadhwa is going to talk about it.
I'll be running you through a few simple strategies on how to manage finances in a community eye hospital setup. These are basically a lot of common sense pointers, but we tend to neglect them in our day-to-day working. I'll start with the golden rule of cost management, because a lot of community eye hospitals face challenges due to rising costs of increasing salary demands, changing patient expectations, frequent change in technology. We'll start with the golden rule: every rupee saved is every rupee earned. However, we need to be cautious about not being too miserly and not cross the threshold by cutting costs so much that it affects patient satisfaction and patient quality. I'll be using the nomenclature in cost management of fixed costs that include rents, salaries, insurance, depreciation, and variable costs directly related to the volume of patients, which include material costs, consumable costs, etc. Another ground rule to remember is fixed costs decrease per unit of service with an increase in volumes. For cost reduction to be effective in any organization, we need to have the leader give importance to it. It should be an important priority in the leader's agenda. The leader needs to be alert and prompt to the changing environment to understand what is the impact of change that's going to bring in the organization. And of course, prompt decision making avoids the opportunity cost of a delayed decision making. We all know emergency requirements and random decisions always are detrimental to cost reduction. Annual goals and activities calendar need to be well in place, because else random decision making, or it's like a postmortem and troubleshooting kind of a situation that we create if we don't have our goals and activities for the year planned well in advance. And handling postmortems and troubleshooting is always more expensive for the organization. Instituting proper controls of expenditure would mean internal audits, a maker and a checker system, having the system of purchase requisitions, and a periodic review of the expenses. Instituting a positive work culture is trying to build a team which is focused on serving the patient. Imbibing this one important aspect in every staff member of serving, and a gentleman's attitude as to what did I do for the organization today? Did I give more than what I took from it? Positive work culture would also include empowerment, reducing bureaucracy, and promoting team playership. Instituting a culture of cost reduction. So many times, we are not aware of the realities of expenses. Like just last week, I asked a manager, what do you think is the electricity bill? And she simply said 25,000 rupees per month. So 25,000 rupees per month for a 40,000 square foot of space was a gross mismatch. So you need to make your staff alert and aware of the realities of the expenses. In addition, you can make them very motivated towards cost reduction by telling them their decision to save costs means they have the power to make a difference. Because of their savings, we could have better increments, invest in better technology, and even serve the patients better. Initially, purchases in any community eye hospital will need to be micromanaged by senior management for the first 2-3 years, and then of course it could be delegated to a competent staff. Comparative analysis always gives rise to better priced substitutes, especially when we network with other players in the industry. We need to manage our inventory efficiently, and of course when we are looking for buying equipment, always look for good service support and low maintenance costs. HR costs play a very significant role, a very big expense in the P&L of any organization. So we really need to start right. Like in the earlier session, we had these tests for the patients. There are a lot of psychometric tests that we do for employees while hiring them. So we start right by hiring a good culture fitting into the culture of your organization, as well as of course competence. Functional training at the start equips them to perform efficiently earlier on in the date of joining. Aligning staff goals to management and organizational goals is really important, because then there's no scattered effect. Everyone is moving in a similar direction, and it helps in a better probability of achieving those goals. Charting out daily, monthly, annual task trackers and a clear demarcation of roles and functions avoids overlap and saves manpower costs. Another way of saving HR costs is a daily reporting of activities by the staff. So at the end of the day, they submit a daily report. That automatically makes them more conscious of what they are doing during the day, and of course subsequently they become more productive. We need to minimize attrition, because there's a cost of hiring and training, and of course there's a loss of quality when one person leaves and another joins, until the second person who joins comes up the learning curve. Empowering your staff, time and motion study needs to be done periodically, where we measure the time taken for every function by every staff member. So it gives you an important idea, like if you need 7 security guards and you have 8, you're overstaffed, Or you need, if you have only 5, you know you need to hire more. Similarly for all categories of staff, including doctors. Harnessing volunteer support. At what cost or efficiency is my outcome being achieved? I'll give you a simple example. When we just started the hospital, we have 4 hospitals in different specialities. So I would send the housekeeping staff to buy me a cup of tea, who would go to the canteen, which is just 2 buildings away. So I realized in a few days, I'm spending 30 minutes of manpower time plus an opportunity cost that she could have done any other job, plus the cost of the tea. So that's a really expensive cup of tea. Analyzing your OR and OP productivity on a daily basis and tracking errors that could happen in your operation theaters and OPD, linking those errors to what corrective action that you could take. Surprisingly, we found corrective action that can be taken even on the policy level, on the process level. Maybe it's an understaffing issue, maybe it's an overstaffing issue. We need to have in place a readily available pool of tasks that could be assigned to staff when there is a sudden drop in volumes. Fixed and variable components of salary always keep the staff on their toes. When I say variable component, I don't only mean monetary incentive. I mean rating every staff member, right from doctors to the housekeeping staff, on performance, on behavior, on attitude and competence month on month as a salary component. Appropriate use of human resources, offloading to counselors, technicians, optometrists, what doctors don't need to do necessarily. Offloading clerical work. Sometimes a lot of managers are busy with very routine clerical work which could be offloaded to junior admin assistants. Having clearly documented SOPs, standardization of not only clinical protocols but administrative processes as well. Overhauling from time to time, like a process re-engineering of all your functions to bring in about an efficiency, effectivity, and also you eliminate any redundant jobs that may be there. Aligning your workflows to cost reduction. A very simple example for this would mean, like if you have 20 camps in a month and you do the BP and BSL on the campsite, you do the BP first because you save that many sugar strips. These small costs over time do form a significant reduction in costs overall. Investment in a robust IT, like in a community hospital, we may have 50, 60 admissions on a day. The same demographic patient data is used at the campsite, it's used on admission, it's used in the OR, it's used on post-op and follow-up. So a robust IT will integrate the systems and the same database will be accessed at every workstation. In addition, of course, the robust IT automates a lot of jobs and brings in about a certain automated efficiency. System of preventive maintenance, of course, will prevent a lot of huge costs of breakdowns, of repairs and sudden breakdowns. Policies do impact your costs in a big way. What is your objective? Is it a profit objective? Is it a not-for-profit objective? Do you want your community volumes to be driven by SICS or FACO? Do you want your consultants to do the community patients or fellows and residents, because that's a significant cost reduction? What is the total capacity you have and how you can scale up volumes? Percentage of non-paying to paying, that's another policy decision. Full-time visiting versus visiting faculty. What are the non-core services which you'd like to subcontract, like for example, housekeeping, canteen, etc. I'll share 2 deeper insights on the revenue front. If we openly proclaim that we are a community eye hospital or a charitable hospital, it kind of dents the positioning of our hospital, it kind of dents the branding of our hospital, and that affects the footfalls of the paying patients. Another problem that occurs is patients who have the affording capacity but don't have the intention to pay will abuse or misuse your charity service, which is meant for the charity patients. We need to account and understand a clear picture of the funding inflows and outflows of the paying section and the non-paying section separately. Identifying the drainers of your revenue. It could be an ROP patient, it could be a corneal transplant, especially when we have low volume of corneal transplants. How are we understanding who's going to pay for this cost? Basically, every function needs to be identified as a cost and profit center. Coming more to the revenue side, we need to identify our key products and services and how we are positioning them to the footfall that we have. What is our target population? We may want to do a lot of premium packages, we may want to do a lot of trifocals, but that's not the kind of patients we are getting with that paying capacity. So we need to understand how we are positioning our services, and accordingly that subsequently that decides how we are investing in our infrastructure. The tariff structure, of course, will be determined by two main pointers. One is your costs. Are your tariffs covering your costs? And of course, you need to limit your tariff to the market prices. Building awareness always helps in increasing footfalls. Data is the new oil. Unless we don't measure, we can't analyze, and we won't be able to manage. Data helps us to measure, analyze, and manage better. For example, what is the capacity that you have? What are you utilizing, and how you want to scale up your capacity? Of course, basic other data that is analyzed is your demographic information like gender, age, sex, which location are they coming from. We also use the data to understand what should be your OPD timings in the evening. Do you roll it back by 1 hour because you're not getting patients between 7:30 to 8:30? Do you shut down your Sunday OPD, or you continue to run it? One important aspect is, where am I investing my funds in, and what are the returns I'm getting out of it? Will I get more returns by investing in this technology and space, or simply by parking my funds in normal instruments like debt, equity, or even an FD? This we need to do by comparing your yearly inflows to the future value of investment. There's a simple formula that does it. Future value of your investment is equal to present value into 1 plus the rate of interest to the number of years. The idea behind this is no asset must remain idle, because an idle asset always incurs opportunity cost. I'd like to wind up on some common pointers of managing finances in a community ophthalmology setup. One is cost management. Optimize your cost cutting. Revenue management, maximize your revenue. And of course, understand what the sources of your funds are going to be, what the cost of your funds are going to be, and where are you going to deploy them. Thank you so much.
Thank you, Ms. Wadhwa. Please stay back for any questions. We usually don't, by custom, we don't ask questions to the keynote speaker, but you've given us so much information that I'm sure there are any doubts, because if there aren't, I have a few. I just want to learn. You gave us a lot of information, so I just want to understand costing, and you spoke about costing as the right costing, especially to go with the market costs. For us lay people who are not really into finance but who want to put a price on a service or a surgery or a procedure, are there simple tools that we can use, maybe online, or instead of going to experts to actually sit down and analyze what is a proper cost?
The simplest tool which worked for us is this: just detailing all your expenses and first giving priority to the maximum expenses. It could be your manpower cost, it could be your electricity, it could be your stationery printing costs, etc. So you put down all your expenses, all your direct expenses and indirect expenses, you total it out, and you also need to do a market survey, because your prices can't go beyond the market. And based on the policy of whether you're profit, not profit, you need to understand your tariff, how much lower you need to keep your tariff than the market, due to also attract patients due to competition. So once you work out your costing with respect to all your expenses and projecting your volumes as to how much you'll be getting in the next 1 year, 2 year, 3 years, you'll come across your break even, and then that will help you to also tweak your market prices.
So we have to do that per procedure? For example, if we have to know...
Initially, periodically it would help, because your main revenue earners are your refractive and cataract. So at least if you unit cost your cataract...
We may just have a patient who comes into the OPD and starts making a fuss outside while sitting and waiting for the doctor, and they start yelling at your staff saying they've been waiting for so long, or they're unhappy with the air conditioner. It could be anything. It need not even be a big thing. But sometimes it can become very disturbing for multiple reasons. Of course, they are loud, they are aggressive, they may be abusive, and it also disturbs the other patients who are sitting there in the OPD. And that happens in two ways, depending on the mentality of the patient who is sitting there. They may actually, feel disturbed or get frightened, or sometimes they may copy the similar behavior and learn from that, because what happens, what they see happening is a patient is becoming aggressive or difficult, and everyone swarms there and starts giving that person a lot of attention and so-called VIP treatment. So they may just, decide that that's the easiest way to see the doctor fast. So let's see what systems we can have in place to deal with this, and we are happy to learn from anyone's experience on patients that they may have seen in their OPD or their practice, as to how you've dealt with these situations. I know Dr. Rajshekhar is sitting here, and I really wanted to bring one example here of how they have, we have, for dealing with emergency situations, there's actually a WhatsApp group called Bangalore Ophthalmic Society Emergency. And that's been quite useful to a lot of people with the upsurge of violence or difficult situations. So what has happened is that, suppose there's a person who comes into the clinic and starts making a ruckus or complaining about something which is a situation which could get out of hand. The doctor could put a message on this group, and the doctors who are close by or who have clinics or hospitals close by would then, potentially rush to help them, because it's always good to have your own brethren, so to speak, standing there and defending, or at least standing by your side. So it's important preemptively, and this cannot be done at the last minute, but preemptively make connections, and that's where many societies do help, that know who your neighbors are in terms of your practice and people who are close by who can help. And of course, if you can, then the local police or any of our protectors, if you also know it. And this may sound quite extreme to think that we now have to keep the police in the loop, but unfortunately we are living in times where you never know. It need not even be something which has gone wrong, it's just a patient's perception. And the way the media likes to blacklist or at least paint things for doctors, you won't have a time to defend yourself before everything gets beaten or someone's assaulted. So it's a good thing to try and figure these things out. Fitting the clinic or the hospitals with CCTV cameras at strategic locations is very useful. This again is for multiple reasons. One is, of course, that it would record an event if something like that is happening, and which is very useful for legal purpose. It also could be a deterrent for someone who is off the mindset or trying to do something if they are not, if they see that. Also, of course, if you can hire some sort of a security guards, but unfortunately many of these are hired out to these outsourced to companies, and they're not really security personnel, so you can't really rely on them. And you can have some sort of alarm system as well in place to, at least if it's a very big hospital and there's a situation in a particular part of the hospital, like how we have our code blue or code red, then there could be a code for these things as well if a patient is getting violent. So, of course, even with the best laid plans, some things can happen, and then you have to use all these precautions that you took up. As I said, it's very useful to have a good relation with your local police if required, and the CCTVs would help you. But unfortunately, even with all this, we're still sitting ducks, so to speak, very often. But how do we try to prevent? So as I said, not all patients are physically aggressive. They could be verbally aggressive or abusive or just difficult patients, and we'll be coming to a few cases of that. But what is very important, that while we are sitting inside our OPD rooms, we don't know what is happening, and many times the problem would have started outside our clinic, so to speak, in the waiting room. And I just wanted to bring something which we use in our hospital, is that the workflow ritual would be, of course, like everyone, is that there would be either a secretary or receptionist who sees the patient first and takes down their general details, and then if an optometrist or some sort of assistant, and then the doctor would see. So it's a good idea to have the hospital staff also primed for so-called odd or difficult behavior. So if a patient is not willing to wait too long, or creating a fuss outside, it's a good idea for them to mark this behavior and bring it to the notice of the doctor before that patient then waits for a long time and becomes very aggressive, or so it could be, some sort of a channel could be created to handle this. We also, sometimes believe that it's not always in the hand of the patient. They may actually have some psychological or psychiatric issue. So if that is there, then it's a good idea to point that out, because otherwise, if they do happen to have a surgery or any problem, then we are sort of setting ourselves up for future problems. And if anything like that would be there, then it's better to avoid the surgery, or take care of other issues first before we go ahead with the procedure. As a doctor, of course, it is our responsibility. We cannot label patients or people, and no matter how difficult, if they've come to us, we have to try and help them. And I think body language is something that we have unfortunately never taught in medical school, but is something which is very, very essential as a service industry. So that body language of the confidence or the empathy is essential, not to sound preachy, but and no matter how difficult the patient is, always lend that listening ear. And we've had patients who come and said that they're allergic to lubricating eye drops, okay? It may sound ridiculous to us because we feel that nobody can be allergic to the lubricating eye drops, but telling them that no, that's impossible, you're wrong, nothing like that happens, can sometimes, something as trivial that can also make them get upset or angry. So it's okay to just say, yeah, okay, possible, and then change the lubricant. It just diffuses the situation. So, and if, suppose, complications are part of what we do, it's, we have to handle them, and if that does happen, then we have to show empathy, but without guilt, because it's a known complication of the procedure, and you make a genuine effort to solve the problem. So rather than avoid a difficult patient, we must meet them, take the time to speak to them, and more importantly, show the patient that you are taking that extra effort. They all appreciate it. Even if we may not be able to solve the actual problem, it's important that they realize we are doing that extra bit. So, for example, if you're giving a concession or writing off an OPD consult, they should know that this effort was made on their behalf, and it goes a long way in showing them that we care and maybe diffuse a difficult situation. So that brings me to the end of my talk, and we would really like some inputs from anyone. I'm sure everyone has cases or ideas that they'd like to add. Yes, Dr. Gairik.
Sure. I think if we can request Dr. Rajshekhar to comment on the first part, how does standalone eye hospital take care of code violates, especially if we are smaller in practice and in strength?
Thank you, Anand. And see, this the violence, it's a scary thing, but fortunately, not so much in ophthal practices. But we should be prepared. The best way of being prepared is being aware of that, and there is always 30 minutes before any such violent act happens in the hospital. There will be some kind of indications, as Sharon was saying. So that is where your staff has to be alert to pick up those small little indications. That's the time we proactively educate staff to call up police, local police station, and best would be to call up 100 number. Rather than calling the nearest police station, it's better to call up 100, and the suggestions given by the police officers is tell them that there is a mob there. Don't tell them that somebody is fighting against a doctor or the violence in the clinic. Just say that mob, because police have been sensitized to act very fast to a mob rather than to a small institution. So they are telling that sometimes the doctor related issue, subjectivity comes in, and if the local police are not happy with that clinic, there are instances that they have delayed in coming to the place. If you say that there is a mob and dial to 100, there is going to be a very fast response. The vehicle that's on the move will come, one thing. Second is the doctor should move away from that place. So that's the, rather than confronting and getting into the issues, one is to move away from the place, because it will always get diluted. This is if there is an imminent problem that is going to happen. And if you expect that something has happened now and towards the evening or in next few days they can come up, then that is the time you can make a complaint, and the police in either civil dress or in their uniform itself, they will get posted. You may have to pay some amount of money, that's fair enough. If police van is seen around, or if police are there in the hospital, then nobody comes. It's only the next 2-3 days. And second thing regarding FIR.
The delay in FIRs.
Delay in
Or
FIR.
rather the delay in conviction.
No, you mean putting an FIR? FIR against the patient and rest of the things. So these things generally are not advised. Generally not advised, because you don't know whom you are fighting with. If you are fighting with a fellow who has nothing to lose and all the time at his hand, you will unnecessarily get dragged into loss of time. Because rather than the conviction, you said 1% will get convicted and all that, but the rest 99 go through the painful process of lodging this and losing peace of mind and all that. So basically, if you have good rapport with the local police and the politicians, most of the 99.9% of the issues can be sorted out. And when I say local police, it's not the local police station, it's at the IPS level. We doctors can sync very well and can communicate very well at the IPS level. You should always reach anything above DIG and above, because DCP office and like that, rather than going to the sub-inspector, assistant commissioner, they're all, they can't sync well with you. The moment you reach a DCP, they'll instruct the local station, and you can directly walk into DCP's office. You are a doctor, you just give a card and they'll take you in, and immediately they'll ask. Basically, this is what happens. Many times we have seen people reach the sub-inspector, and his mindset and his way of solving problems, actually they increase the problem, because, and reaching them first, whoever reaches them first will have an advantage. If the patient reaches them first, he gets an advantage, because then they try to see you as the accused.
Thank you so much.
Yes, thanks, Sharon. We come to the last part of the instruction course, which is on cases and also some open house discussion. So if anybody would like to share a case where they had with a difficult patient, here we are more so looking at litigation, about how patients have gone against you. There are two places where they can go, either to your medical counsel and go against and complain against you for malpractice, and this second one is that they go to the consumer court itself. So how are you going to deal with these kind of cases? Again, I think Dr. Rajshekar is a good person here discuss about it, because he's the head of an institute and I'm sure he's facing a lot of such issues. Luckily for us, because we don't come up with too many medico-legal issues, there are no RTAs, so to say, where it's not like we just don't have any, but the response of these kind of patients is much lesser for us, because they come to us after all that process is already over. As a presenting patient, to us, it's there, but very, very less. So to share a couple of cases that we at Narayana Nethralaya have faced is, some things that are beyond our control. For example, we had a patient who's a known patient of retinitis pigmentosa, who has gone, unfortunately, to some other person and has not even been investigated or has documented retinitis pigmentosa, gone ahead for the refractive error with a clear lens extraction and then augmented it with a LASIK. Now the patient comes to us with a presenting vision of 636 in both eyes, but then on follow-up, we have already documented that the patient has retinitis pigmentosa. On follow-up, due to whatever the initial surgery was, the patient had an IOL dislocation. Now obviously we had to take care, the patient was under our care now, we referred the patient to a cataract surgeon who managed to put in a glued IOL, because at that point of time that was a technique of scleral fixated IOL that was being followed. Now the patient did not have an extremely good outcome, because the patient already has retinitis pigmentosa. They are known to have be prone to macular edema, and secondary to the scleral fixated IOL and the inflammation, the patient's vision dropped down to 660. Now that now is still in court, because though at our Karnataka Medical Council the doctors were shown to be not at fault, right from retinitis pigmentosa to the clear lens extraction to the LASIK to the IOL dislocation, now Narayana Nethralaya is being held responsible. Whereas the only intervention that was done from our end was a glued IOL, which was the only option available at that time. Maybe now we would have tried some other technique, but at that point of time that was the technique in vogue. So we are now faced with situations like this, wherein you cannot defend for all the things that happened before, but you are the surgeon being held. I'm sure all of us are faced with such situations. So how have you all kind of handled it? Do you have some pointers for the audience and the participants as to how you really face with it? Because you don't have any documentation prior to the patient walking in, which showed obviously retinitis pigmentosa was there, but how the previous surgery went, what was the macular edema, did the patient had any inflammation post the IOL surgery? We don't know. The patient just presents to us with 636. So this is one such incident. And Dr. Anand, I think you deal with a lot of young infants, because you treat patients with retinopathy of prematurity. Have you faced with a situation like this?
So part of it we covered a little earlier in terms of making this decision on behalf of a minor patient. Yes, I think it's very important, because we do get patients who've been treated for ROP many times, let's say when, and this I think it can happen in any condition, when you kind of don't agree that the baby require treatment. That is one aspect where you're sort of, that comes actually into the next topic of how do you deal with so-called mistakes of your colleagues or complications of colleagues. But here it is against a pediatrician. So they ask the question, if my baby was seen on time, could this blindness have been prevented? Obviously the answer is yes, but how do you say it in such a way that you protect that pediatrician, at the same time convey the truth? Because if this person decides to go to court, your having said that ROP cannot be prevented if it is not seen on time will be held as falsehood. So these are very difficult situations, and what we end up doing in our institute is that we examine the baby. Usually these babies come very small, so we see them without the parents in the room, so we kind of know the diagnosis, and then we get all the referral letters, and we've made it a habit to speak to the referring doctor, be it the ophthalmologist or the pediatrician, and find out what happened. And most of the times there would be a sort of a co-negligence where the pediatrician would have probably told them to go, but they did not, or there was a life and death situation, the child had to be kept alive and screening was just not possible, or actually screening was done but the parents hid that fact from you. So all of that would be possible if simple communication lines have been established. Once we ascertain the actual facts, we call them inside and we begin by telling them the long story, what it could have been, what it is now, and then where we are from now. And I think it's important to use the words like, they tried their best to keep your baby alive. It's 700 grams, the baby could have died, but now one of the possible complications is this. We've reached a point where, if you use accommodative language like that, they may understand at the end of the day that, yeah, maybe it could have gone a better way, but they are not aggressive, they don't confront, and they're not litigious straight away. Well, there are at least 6 cases going on in Karnataka state against pediatricians that I am aware of, and all of them are going to go against the pediatrician. But there are 1,000 more that have not gone to court. So, and I think it's the way we communicate.
I think that's what even Sharon was very clear about when she spoke. I think communication with your patient and taking them into confidence, trying to cover up. I don't know whether Dr. Rohit will be able to make it, but I think as professionals, we always have to cover up for our colleagues, our friends. They may be your competitors, but you may be at the receiving end. So we have to say, given the circumstances, I think your doctor, primary physician has done the best. But every day is not a good day, and then we just need to go forward and handle the complications. I think that would be the best way to handle it if we are faced with these kind of situations as well. Are we expecting Dr. Rohit?
No, I think we're at the end of the session. We can stop.
I think we can, we will need to wind up because we have the
Next course
session
ready.
Yeah, and we're getting some dirty looks from sir there.
Thank you so much for being part of this sort of a different kind of a course, and we hope that your feedback will reach AIOS.
Yes,
Thank you so much.
Thank you.